A young male presents with acute pain following a fight. I am showing you the radiograph of the hand. Describe the findings.
Okay, assessing the provided imaging. The hand radiograph demonstrates a well-defined expansile lytic lesion in the diaphysis of the fifth metacarpal. There is thinning of the overlying cortex, but no cortical breakthrough, periosteal reaction, or associated soft tissue mass. The lesion has a narrow zone of transition and is located centrally within the medullary canal. No acute fracture is identified. These findings are typical of a benign enchondroma.
What is the differential diagnosis for a lytic lesion within the digits, and which clinical features should we consider?
Well, the differential diagnosis for a digital lytic lesion can be remembered by the Mnemonic SEGA GAME F. This includes simple bone cyst, enchondroma, giant cell tumor of the tendon sheath, aneurysmal bone cyst, glomus tumor, osteomyelitis or abscess, metastasis or myeloma, epidermal inclusion cyst, and fibrous dysplasia. Clinically, enchondromas are usually asymptomatic and discovered incidentally or when a pathological fracture occurs. Glomus tumors present with intense pain and typically involve the subungual distal phalanx. Epidermal inclusion cysts also target the distal phalanx and are associated with a history of trauma.
I am showing you a radiograph from another patient with multiple similar lesions. Describe the findings and name the syndromes associated with this condition.
Okay. This radiograph demonstrates multiple expansile Lucent lesions throughout the tubular bones of the hand, consistent with multiple enchondromas. The presence of multiple enchondromas is diagnostic of Ollier's disease, which typically has an asymmetric distribution and can lead to limb shortening. If these lesions were accompanied by multiple soft tissue hemangiomas containing calcified phleboliths, the diagnosis would be Maffucci's syndrome. Maffucci's syndrome presents later and carries a significantly higher risk of malignant transformation.
Discuss the radiological features that suggest malignant transformation of an enchondroma to chondrosarcoma.
Malignant transformation should be suspected if there is growth of a lesion after skeletal maturity, or if the patient develops pain in the absence of a pathological fracture. Radiological features suggesting malignancy include cortical erosion, cortical breakthrough, a soft tissue mass, and new or rapidly increasing periosteal reaction or calcification. Malignant transformation occurs in up to 25% of patients with Ollier's disease by age 40. It is more common in central skeleton lesions, such as those in the pelvis or proximal femur, than in the hands and feet.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing this hand film with prior studies if available to confirm stability. I would suggest obtaining a complete skeletal survey or radiographs of the opposite hand and long bones to evaluate for multiplicity. If the patient reports localized pain at the lesion site without an acute fracture, I would recommend a contrast-enhanced MRI to evaluate for endosteel scalloping and cortical breach. Finally, I would recommend referring the patient to an orthopedic specialist for clinical monitoring, as curettage and bone grafting may be indicated if a fracture is imminent.